On behalf of the Association of Maternal and Child Health Programs, welcome to this listening session on transformation of the Title V MCH Services Block Grant, sponsored by AMCHP in partnership with the Maternal and Child Health Bureau, Health Resources and Service Administration. As noted, this is Millie Jones, and I am president of AMCHP and the co-chair, together with my colleague Stephanie Birch from Alaska, of the AMCHP Future of Title V Work Group. It's a work group that was formed in February 2013 by the AMCHP Board of Directors to provide input to the Maternal and Child Health Bureau on the transformation of the Title V MCH Services Block Grant. We are delighted to be here today to provide a forum for state Title V MCH program directors and their staff to participate in a national dialogue with Dr. Michael Liu, Associate Administrator of the Maternal Child Health Bureau, on the transformation of the Title V Block Grant. AMCHP has been a key leader and advocate for the Title V MCH Services Block Grant and a close partner of the Maternal and Child Health Bureau for many decades. We want to thank Dr. Liu and his staff for their leadership and efforts to transform the Title V Block Grant, for actively seeking the input of states in this effort, and for their partnership with AMCHP. As we all know, the Title V MCH Block Grant is the foundation on which many programs to help our nation's most vulnerable children and families are built. Now more than ever, particularly in an era of health reform, the activities that are supported through this historic federal-state partnership are critical to protecting and promoting the health of America's women and children. While health insurance coverage is essential, alone it is not sufficient to improve the health of MCH populations. Indeed, the United States will not completely reduce health disparities or improve health outcomes unless there is a sustained effort to strengthen the public health systems and services that address the root causes of disease and poor health in America. AMCHP has had one clear goal in our efforts to provide input to the MCHB on the Title V Block Grant transformation. And that goal is to ensure that Title V MCH Block Grant continues to be a viable federal-state partnership and thus a locus of accountability in every state for our nation's mothers, children, and their families, particularly those who are the most underserved and vulnerable. As our national association and representative in Washington, we strongly support changes to the administration and implementation of the block grant to ensure that Title V continues to meet the needs of MCH populations in today's evolving healthcare environment and with limited public health dollars, to be responsive to state needs and reflective of how states use the federal dollars, and most importantly, to improve quality and accountability. Stephanie Birch established the AMCHP Future of Title V Work Group during her tenure as president of AMCHP, and we have co-chaired the work group together for nearly a year. Thank you, Stephanie, for your leadership, vision, and tenacity with this effort. Now I'm going to turn it over to Stephanie to talk about the purpose of the session and to introduce Dr. Liu.
Thanks so much, Millie, and good morning to all of you. I hope you're staying warm. Surprisingly, Alaska is warmer than probably most of the lower 48, so I hope you're warm and safe. I want to also echo Millie's comments on the importance of this work overall and to recognize the importance and significance of these listening sessions, which are really milestone and a culmination of work over the past 10 months to seek state input to the Title V transformation and present that to Maternal Child Health Bureau on your behalf. That input is formally outlined in 2 of the AMCHP memos that you received from AMCHP staff and were distributed again in advance of this listening session. The Future of Title V work group has engaged in countless hours of work to get the content of those memos and in additional conversations with Dr. Liu, really reflecting on your comments. I want to thank the Future of Title V work group members for their leadership and participation in this work. Those members include, as Millie mentioned herself, President-elect Sam Cooper from Texas, Valerie Richter, Deb Waldron, Karen Truerweller, and Nan Streeter. In addition, your board has been active in smaller work sessions to prepare documents and refine the information in support of these listening sessions. I want to stress the purpose of these sessions is threefold. First, to provide an opportunity for Dr. Liu to present his vision for the transformation of the Title V block grant directly to the state Title V programs and their staff in a national webinar format. Secondly, is to provide a format for the MCH Bureau to obtain further input on the block grant from states and to answer your questions. And third, to provide states with information on the next steps of this work over the coming weeks at the MCHP annual conference, which I hope many of you are going to attend, and then through February 2014 and beyond. During the session, you're going to hear from Dr. Liu for about 30 minutes, and then we'll be opening up the conference call lines for an interactive dialogue and exchange. You'll have opportunities to vote, and I really want to stress that this is a listening session. Brent Ewig and Karen Van Landeham will be chairing and facilitating the question and answer period. Before I introduce Dr. Liu, I'm going to turn this over to Carolyn McCoy of the MCHP staff to briefly view the logistics for asking questions during our listening sessions. Carolyn?
Thank you, Stephanie. Good day, everyone. I just wanted to quickly go over a few housekeeping items that have to do with this listening session. I just wanted to note, if you don't hear me, then you don't hear me. But if you can see this, then this is a phone number to dial in. Hopefully we are all with you. If you have any issues, please feel free to chat the chairperson, and I will get back to you as soon as possible as well. Or you can email me. There's my email address, cmccoy@amchp.org. And we really want to promote that this is a listening session and a dialogue. So the main way, the most apparent way and a way to promote the dialogue of this listening session is to provide comments and feedback through your audio line, which we've provided instead of just through your computer. And the operator will provide instructions on how to queue up at the moments when we're going to be offering opportunities to comment and offer clarifying questions. But if you have a short, brief, clarifying question or maybe a comment that you just want to submit over the chat feature, feel free. But again, we really please submit that by typing in the chat feature in your lower left-hand corner of your webinar screen and submit that to the chairperson, and we will see that come through. But again, we really do want to encourage you to submit your comments over the phone, being that this is a listening session. And finally, the webinar will be recorded. If you have any issues with that, then we're letting you know you can disconnect. And we will be posting this to the MCHP website in about a week's time. And finally, as Stephanie mentioned, we will have a voting feature throughout the webinar. So stay close to your computer and your mouse, and we'll provide you instructions when that opportunity arises. So I'd like to turn it back to Stephanie.
Thanks so much, Carolyn. And now it's my honor and pleasure to introduce Dr. Michael Liu, Associate Administrator of the Maternal Child Health Bureau. Dr. Liu?
Thank you, Stephanie. And I want to thank the staff at AMCHP for arranging this listening session. And I also just want to take a moment to thank Stephanie and Millie and really the entire board of AMCHP, especially the Future Title V Working Group, Sam and Valerie and Deborah and Karen and Ann, for their tremendous leadership and partnership. We've been working on this for more than 10 months now, and the board's advice and guidance, which I know come from decades of working on the ground with mothers, children with special health care needs and their families in states north and south, big and small, urban and rural, have really helped sharpen this working vision, which I think is a really good demonstration of the genius of Title V. That federal-state partnership, which recognizes that Washington doesn't have all the answers, that the real work of improving maternal and child health in our nation really happens on the ground at the state and local levels, and that it happens when we come together, federal, state, and local, e pluribus unum, out many, one, and that's what we're trying to get to, that one common ground that all of us can stand upon, that one common vision for transformation of the block grants. And we know that vision is still not quite 2020 yet. It still needs sharpening, needs focus. That's why I made a video to reach out to a broader community of MCH stakeholders to get your ideas, your input. I want to thank those of you who've already taken the time to write me and encourage all of you to keep your ideas coming at mchtransformation@HRSA.gov. And let me just make a correction here. I don't know how many of you actually watched the video to the end. At the end, I did make a mistake. I said mchtransformation@.com. That's actually wrong. Okay, the correct address is mchtransformation@HRSA.gov. And this is also why we're having these listening sessions, and I do mean listening session. Okay, this means I listen and you talk. This is my chance to listen to you, to hear your ideas and input, your questions and concerns, your hopes and aspirations for Block Grant 3.0. So I'm not going to repeat what I've said in the video already. For one thing, I want to thank those of you who were patient enough to sit through me talking straight for 28 minutes and 37 seconds. I'm not going to put you through that again. Instead, I'm going to ask you 4 questions with one common theme. Did we get it right? So the first question I want to ask you is about mission vision of Title V, and really what Block Grant of the Future, Block Grant 3.0 is all about. In the video, I said our mission is to improve the health of all of America's children, mothers and children, and we will carry out this mission not only as parent of last resort, but as the public health system for MCH populations in all 59 states and jurisdictions. This means that we have to have the right tools to carry out the public health core functions of assessment, assurance, and policy development. This means that we have to have the right tools to drive improvement in access, quality, integration, equity, and accountability in the states. And as for framework, this means that we're moving away from conceptualization of Title V as levels of the pyramid and moving toward a public health framework which focuses on the central role of Title V as the public health system for MCH populations in all 59 states and jurisdictions, and the public health functionalities of assessment, assurance, and policy development, and the 10 essential services of public health. Now, what I want to hear from you is this. Did we get this right? The second question is about reducing burden. And as I said in the video, I heard this loud and clear from many of you. And let me just ask, Carolyn, should I pause for a minute? For
Dr.
people
if you'd like folks to respond to this, we have some results coming in.
Okay, so tell me when I should keep going.
If you folks would like to respond, we'll give you a few more seconds. So stay close to your mouse and please register your vote results. Okay, we're seeing a little bit of a slowing. I'll give you a few more seconds. Okay, wonderful. We're still climbing. We have about 50 responses. How about 5 more seconds? Okay, Dr. Liu.
Thanks, Caroline. And I want to thank the staff at AMCHP. Yesterday, while we were doing the listening session, I expressed to them I wish there was a way. We were getting feedback and input and comments, but I told them I wish there was a way that we can take an instant poll of just how folks are feeling and whether they feel like we're on the right track. And they made it happen right away. And so again, my deepest gratitude for just the tremendous partnership and leadership that AMCHP, both the staff and the board, has provided us in this process. All right, let me move on to the second question, which is about reducing burden. As I said in the video, and again, I heard this loud and clear from many of you, the current application and annual report process is too burdensome. And so we set out to reduce your burden by half. We propose to do so by, first, reducing your data burden. Wherever possible, we will pre-populate your state data with national data resources rather than for you to have to look for your own state data. Second, aligning and streamlining the needs assessment, annual report, and application, as I described in the video, to reduce redundancy and improve accountability. Third, simplifying, clarifying, and reducing the number of forms that you have to fill out. And fourth, doing away with the health system capacity indicators altogether, which I heard should substantially reduce burden. So if our aim is to reduce your burden, again, my question to you all is, did we get this right?
Again, we'll give you about 20 seconds and then show you the results. And we'll close this out. There's the results.
Thank you. The third question now is about maintaining flexibility. As I said in the video, we have to strike a balance between being able to tell a national story about how Title V is moving the needle in MCH for the nation as a whole, while maintaining sufficient flexibility for the states to address your state needs and priorities. And that all begins every 5 years with your state's needs assessment, which should be an assessment of your state needs, priorities, and capacities, which is then followed by your state-specific performance measures. We expect you to develop, monitor, and hold yourselves accountable to at least 5 state-specific performance measures that you'd like to move the needle on in the next 5 years in your state. Your state performance measures can be the same as the national performance measures, but they don't have to be. And really, they should be driven by your state's needs and priorities based on your state's needs assessment. And let me also clarify that when I said separate accounting of federal and state Title V dollars, I'm just talking about counting, and you all know the reason for that. It doesn't mean that every federal dollar has to be spent on national priorities, on national performance measures. You will still have the flexibility to spend federal dollars on state priorities, much as you might choose to spend some of your state dollars to drive some of our national priorities. The focus here is really about getting results. I'm less interested in how you spend the money as long as it's accountable. I'm much more interested in you getting the results, getting the job done. And let me add a fourth part to maintaining flexibility, which are the structural process measures, which I touched on briefly in the video. Now, as you all know, public health is much more than publicly financed healthcare. It's about having the right programs, right policies, right systems in place for assessment, assurance, and policy development. So the structural process measures is a way of making sure that these programs, policies, and systems are actually in place in your states. So let me give you an example. If our population outcome measure is infant mortality, and our performance measure is breastfeeding as a way to reduce SIDS and SUID, then an example of structural process measure might be the number or percent of baby-friendly hospitals in the state. Now, these are called measures and not just strategies, because you will be held accountable, or actually, let me put it this way. You will hold yourself accountable to getting it done. And that's why they're called measures and not just strategies. We believe that states should have the flexibility to develop your own structural process measures and hold yourselves accountable to them. We only ask that these measures be evidence-based, and we can work with you on that during the annual review. So again, if our aim is to maintain flexibility, did we get this right?
About 10 more seconds, and then I'm going to try and allow for a few seconds for the results to pop up. I think there's a little delay. Okay, last call. Okay, just let a couple seconds for the results to show up, and then I think we're ready to go.
Great. And let me get to my last question, which is about improving accountability. And as I mentioned in the video, accountability is about measuring and delivering results, demonstrating return on investment. For our purpose, accountability is about telling a national story about how Title V is moving the needle in MCH for the nation as a whole. And the most controversial part of this is going to be the national performance measures. And believe me, given how diverse our populations are, how broad our legislation covers, it's really hard to pick and choose 15 national performance measures. Our internal work group worked on this for more than 6 months, reviewing all the existing clinical and population-based measures, including the life course measures identified by AMCHP's work group, reach out to some of the best and the brightest measurement experts in the nation, including some of you, and came up with this initial list of about 40. So we went through these one by one and by process of elimination came up with a list of 15 straw measures. Now, some measures were eliminated because they cannot provide state representative data on an annual basis. Some were eliminated because there's little that Title V can do to move the needle. Some were eliminated because they really don't have the communicative power to speak to legislators and appropriators about the value of Title V. And remember, these performance measures should help us tell a compelling story about the impact, the return on investment of Title V for the nation. So my question to you all is this: did we get this list right? Are these the right MCH priorities for the nation, the right MCH outcomes we want to move the needle on by 2020? I know we all have our own pet measures, but I'm going to ask you to put on your leadership hat. If we want to sustain and grow federal investments in Title V, are these the right performance measures? When you send me your ideas, don't just tell me what you want. Tell me numerator, denominator, data sources that are national in scope and state representative and updated annually. And most importantly, tell me why it is strategic for Title V to focus on moving the needle on this for the nation for the next 5 years. And tell me also, is 8 out of 15 the right number? Now, this is like Goldilocks, right? Too many and the states won't have enough resources to move the needle on all the measures. Too few, and the legislators and appropriators start to question the value of Title V. Now, we've got to get it just right. I've heard 10, I've heard 8, I heard 5 for smaller states and 10 for the larger states. What's the right number of national performance measures that the states should be accountable for? Now, let me take a pause here. Caroline, I see the poll is up. Are we doing the poll for improving accountability? And do we have a poll for the number of performance measures?
I think we need to display the performance measures slide first. I apologize for this. Okay. I think this one was misplaced. I think we need to move one slide forward.
Okay, so let me go and finish this part, and then we'll take the poll. And then lastly, in the video, I talked about realigning strands and in all of our programs with the state block grant, and you're seeing the beginning of that movement with the coin on infant mortality, the redesigned ECCS, our new MCH Workforce Development Centers, and you will see more of that in the coming year with the redesigned AIM grant, the D70 program for children with special health care needs, and so forth. I also talked about moving toward an in-state block grant review. Now, as I mentioned in the video, we can't afford to do an in-state block grant review for every state every year, but every state will have a chance to host an in-state review during a 5-year cycle, with the other years staying with reviews in the regional offices. So again, the question is, when it comes to improving accountability, do we get this right?
Okay, about 10 more seconds. Okay, and last call. Okay, and then I'm going to display the results. Okay, the results should be displaying.
Great, thank you. And then lastly, let me just go ahead, before I turn it back to Brent, who's our moderator for the listening session. Let me just remind you all that this is a listening session and not just a Q&A. For one thing, questions and answers presume that you have all the questions and I have all the answers, which I don't. In fact, I think the answers are really out there, and that's what we're trying to get to. We'll certainly take some questions for clarification, but I do want to make sure that we spend the majority of our time today in the listening session where I listen and you talk. This is really a chance for MCHB to get ideas from you, to get input from you, to make sure we're on the right track. We have to put out new guidance in 2015, and considering the OMB clearance processes, we got to start to rewrite the guidance by February of next year. So we have about a month. We're holding these series of town hall meetings. We'll have a town hall meeting during AMCHP, and then after that, hopefully we can come to some common ground that all of us can stand upon, that common vision that will inform the writing of the new guidance in 2015. So with that, let me turn it back to Brent.
Terrific, and thank you, Dr. Liu. I think that was some great framing and setup, but as you said, your whole orientation to these sessions was really an opportunity to listen from the states broadly, and so if I could get the operator to let folks know how to queue up, we'll begin that dialogue.
Thank you. Telephone participants can register a comment or a question by pressing the 1 followed by the 4 on your telephone. You will hear a 3-tone prompt to acknowledge your request. You may withdraw your registration by pressing 1 followed by the 3. If you are using a speakerphone, please lift your handset before entering your request. One moment, please.
Great. So while we have people queuing up, just to reiterate what Dr. Liu said is, he's hoping to hear from you, and so we certainly know, and based on our experience yesterday, that there's certain clarifying questions that you all have, and so we definitely would entertain those and welcome them. But he's also looking, as he said, feedback on the specifics around the straw person measures, the number of measures, so things like that, and being as specific as we can with our feedback is how we can be most helpful. So just reiterating those key points, and let's see if we've got comments ready to roll.
There are no comments on the phone line at this time. However, ladies and gentlemen, as a reminder, please press the 1 followed by the 4 on your telephone keypad.
Great. And for an option, this is less ideal because I think it is better to have dialogue. But as you all see, there is a chat function that is that works with the webinar, and so for those more introverted or teleconference shy folks, we can certainly get your comments that way and read them out if that's an option as well. But again, hoping to have as much dialogue. Let's see. So we're getting a question already about the proposed national performance measures. Would they replace all the existing measures, including those for children and youth with special health care needs? And so, Dr. Liu, do you want to field that, or?
Yeah, that's right. I mean, we are completely revamping the national performance measures, and again, this is just a straw list of performance measures. They are meant to stimulate a national dialogue, discussion, and deliberation about the right set of performance measures to measure the success of Title V. Now, we may end up with some of the old measures in the final list, but we got to take a hard look at each and every single one. And again, when we're asking for your input, please think about the numerator, denominator. Make sure that the data sources are national scope, state representative, updated annually so we can track states' progress toward that. And most importantly, is this the right performance measure, the most strategic performance measure to demonstrate the value, the impact, the return on investment for Title V?
And I'll pick up on that. I think, as Dr. Liu framed this, our whole goal here is to improve our collective ability to tell a story about what the Title V investments are doing. And I think if there's a shift that I've sensed, it's in past that some of the orientation was let's measure everything that's important to maternal and child health, and that is an important function to have. That's obviously foundational assessment. But I think if there's a shift, it's to let's measure more precisely in our performance measures where the Title V investment is focused on, what issues, and the balance here, to state probably the obvious, is the dance we're doing is that the Title V legislation very broadly defines the mission to improve the health of women and children, and to do that by providing quality MCH services without getting too in-depth into what specific MCH services. And as you all know, the challenge we face is a lot of legislators today think only in clinical terms, that when they see MCH services, they're thinking, prenatal care, well child visits, the clinical components that are important. But I think what this alludes to is this idea of here's the things that we do in addition to health insurance and health services that Title V is paying for, and that we can do a better job of saying, a national picture, here's where maybe not every state, but the vast majority of states are investing in these core areas that they've chosen, and here's how we're seeing the needle move. So that's a little more on framing. And operator, if you can just let us know if you want to jump in when we have people in the queue.
Certainly, we do actually have a comment queued up.
Good.
So our first comment comes from the line of Kathy Burke with Mississippi Department of Health. Please proceed.
Thank you. This is Dr. Deanne Richardson, the State Dental Director here in Mississippi. And my question, first I wanted to thank AMCHP and Dr. Liu for your leadership in developing these national performance measures. And in specific reference to the oral health measures, after reviewing them, I thought that they were really on point with what we need to assess. My concern is that, I think, and it was alluded to earlier, that every state may not have the capacity to measure the percent of women who had their teeth cleaned, or assessing children under the age of 6. Again, state oral health programs currently are doing assessments on third graders for the most part. Although I love the idea of assessing children under 6, states are not always supported or don't always have funding to do that. There may be a need to tweak a little bit more or be a little bit more specific about an age group that we could either develop an assessment for or use the current assessment tools that we have available to make those assessments. Likewise, with pregnant women, states wax and wane on their support for oral health benefits. For instance, in Mississippi, we had benefits for pregnant women, but they were lost due to loss of funding for dental benefits for pregnant women in that program. So those are just things that I would make note of and potentially consider maybe some other ways or find some other measures that could get at what you're achieving or anticipating achieving. Thank you.
Great. Thanks very much for that comment. I'm not going to respond to each of these comments so that we can maximize the time that you all have to provide your input. I'll just respond really quickly to this one because the way we're thinking about the oral health measure, the assessment of the cavity in early childhood, that's going to come from our National Survey of Children's Health, the redesigned National Survey of Children's Health. That's going to be updated annually. And remember, we're going to be pre-populating your data reporting for you wherever we can in order to reduce your data reporting burden. For the pregnancy measure, that's going to come from PRAMS, but as most of you recognize, PRAMS is in all states, but it's in most states. And that's why the states do have the flexibility to choose among these national performance measures, because there are some things that are going to be higher priorities than others for your states, and there are some things that you might not be able to measure in your states that other states might be able to. So again, yeah, there's a question out there to all in terms of what's the right amount of performance measures that we should expect the states to move the needle on. Again, the whole Goldilocks rule, we can't have too many because they become too burdensome for the states. We cannot have too few, otherwise the value of Title V starts to get questioned. We got to get it just right.
Pardon me, this is Daisy. We do have another comment on the phone line.
Please go ahead.
Our next comment comes from the line of Ruth Shepard with the Department of Health. Please proceed with your comment.
Hello, this is Ruth Ann. My comment relates to school readiness. Two concerns. One is that it's defined differently in every state and that it's difficult to measure, and many states are not measuring it at all, and the ones that are all measure it differently. And the second is, if we call it school readiness, are the legislators going to see that as a role of Title V, or are they going to see that as a role of education?
Okay, again, great question. Now, the way we're looking at this measure is that they will actually come from items in the redesigned National Survey of Children's Health, and we're actually doing a lot of reaching out to the best and the brightest in our field in terms of what are some of those components of school readiness, and not just the cognitive part of it, but all the components that help children succeed, that help children learn. And we had suggestions yesterday, maybe what we're looking at is not just school readiness, but really early childhood development. But the question really, and that's a question for you all, is whether you feel like Title V should play a role in promoting early childhood development, and if so, what role should Title V play, and what measure they should be held accountable for.
And if I could just add personal perspective, thank you, Ruth Ann, for the question, and the issue of variability in measurement. My daughter is about to begin kindergarten. We asked the principal in her school how she defines kindergarten readiness, and she said the child knows when they're going to throw up and they know when they need to go to the bathroom. So, little comic relief for the afternoon. But we won't be measuring that in Title V. Let's keep going. Operator, do we have others on the line?
There are no further comments at this time.
So we've got a couple in the comment box that I don't believe everyone can say. And some of these, Dr. Liu, we can just, I think, some quick clarifications. One was just a question, a clarification when the needs assessment is due. And I believe that it will be this July, but let's confirm that.
It's going to be due, Cassie, you want to answer that?
Yes, it's not due this July 14th. It's due in July 2015.
July of 2015.
July 2015.
And if I could just add to that, because obviously the guidance will come out too late for us to make drastic change to how the needs of, to our expectation for the needs assessment. But on the other hand, what we want to kind of emphasize is that there should be a better alignment between the needs assessment and your application and annual report, because a lot of the duplications, a lot of the redundancies actually come from the misalignment between the needs assessment, the application, and annual report. We also want to make sure that in your needs assessment, certainly it's about assessment of your state's needs and priorities, but also take some time to look at your state's capacities and resources and needs with respect to those national performance measures. And again, because of the OMB clearance processes, by February, we will probably have an initial final list of these national performance measures, and we want to encourage states to really look at these national performance measures and to really conduct their needs assessment around how their states are doing around these national performance measures, in addition to their own state needs and priorities.
Perfect. And operator, actually, if you can just jump in as people do queue up, but a related question on that, Dr. Liu, was clarification on which federal fiscal year the transformation would be implemented. And I think you just said it would go to OMB this year, for almost a year's review. And just help me if I'm getting this right. So this is guidance that would become effective in January 2015 calendar year, and so it would affect the fiscal year 16 application would be the first year, if I'm reading that right. Is that correct?
That's right.
Timeline? Okay. That was Lori?
Really, we're looking for then that 5-year cycle from 2016 to 2020, and asking the question, how best can we move the needle on MCH by 2020? Yep.
And Brent, this is Kathy. Just to be clear, it would be due in July of 15, and you're correct, that would be for the federal fiscal year 2016, and it would be for the 2014 annual report, but the actual submission date would be in 2015.
Good. And we do have additional comments here, but like I said,
Pardon
I think
for the interruption.
Yep.
We do have a comment on the phone line.
Perfect.
Our next comment comes from the line of Catherine Azale with Wisconsin Department of Health Services. Please go ahead.
This is actually Tim Markle with the Department of Health Services, and I thank you, too, for the excellent work that's been done. And this has been a lot of work. And as usual, I will defer to the great expertise that is out there. But as this is a listening session, I do have a few comments from looking over the list of the straw measures. My first comment is, with reading over the desire to not have to change the statute, with that set aside of 30% for children and youth with special health care needs, I'm kind of seeing children and youth with special health care needs wrapped into the straw measures, but I'm very worried that we would sort of lose sight of the unique needs that the families have for support who have those children and youth with special health care needs that aren't going to be able to get that help through the normal systems, who will need to access the specialty resources and the various needs that they have as families and children with special health care needs. So I want to make sure that they don't get lost in the bigger picture. My other concern is the fact that we are very large in Wisconsin on family leadership and family involvement. And I have a feeling this is an area where we're struggling to find measurement, to measure the effectiveness, to measure the increase in family leadership. But I'm very worried that if we don't involve the families in the leadership of maternal child health, then we're forever going to be telling people what's best for them and telling people what they should do instead of empowering them to do the right thing. Instead of empowering them to make the right choices, make the best choices, the easiest choices. Without that family leadership, it's always the outside voice that is telling families what they need to do. And I'd really like to see some sort of measurement for family involvement and family leadership on a national level. The other thing that we're looking at is the Department of Health in Wisconsin is looking at trauma-informed care and adverse childhood experiences. And I'm wondering how that might be able to be wrapped into national measures, knowing that that's already measured, knowing that we have those rates, knowing that we have people asking those questions. If we could cut down on the incidence of injuries, on the incidence of abuse through using maternal child health dollars, then obviously the health of the children are going to improve. And so I would encourage also maybe looking at the ACEs, even though you probably already have, but that's what listening sessions are for, is for us to talk. And so I would also like to just put out there for the ACEs and maybe look at some trauma-informed care. The last thing is I look at this list of straw measures, and I love health, and I love the medical community, but as part of what I've been hearing is we're trying to differentiate MCH from affordable care and MCH from medical, from what the medical department does and the medical community does. And it seems to be a lot of our straw measures, preconception care, maternal morbidity, early elective delivery, perinatal regionalization, is we run the danger, possibly, of the senators, the legislators saying, well, isn't that going to be taken care of by the ACA? Shouldn't that be taken care of by the medical community? How is this different from what the Association of Physicians say should already be done? Are we doing the work that the doctors are supposed to be doing? So I would just really, maybe it's a framing thing, but when I first read it, I'm sitting there going, this is what the medical community should be doing. Why is public health pushing the medical community? I understand pushing public health, but we just, I'm just a little weary and would like to make sure that we don't overstep what we're trying to do, but really focus on our core measures. So thanks a lot for listening. I like listening sessions. Thank you.
Right, and thank you for those comments. Just for clarification, I want to make sure that the 30-30-10 requirement in the legislation will stay intact. This transformation is not about changing the legislation, but really we're staying very, very much consistent with the legislation. I applaud the comment about children with special health care needs. Certainly, when we do the data reporting, we will call out specifically children with special health care needs. And really, I think there are a number of these performance measures that speak to that. We've been stuck nationally at less than half of children with special health care needs having access to a medical home. There are going to be important insurance coverage and adequacy issues for children with special health care needs going forward. I think these are the things that we need to be tracking. We'd love to hear your input and idea to make sure that children with special health care needs aren't lost in this transformation. Also wanted to point out that an important component of how we measure medical home through the redesigned National Survey of Children's Health is about family engagement. We also need to think creatively, and again, your intellectual leadership on this is going to be important, about how do we also think about structural and process measures that make sure that there's real, genuine family leadership, family engagement. Yesterday we had a question come up about Form 13 and whether that will continue to be used. And I've heard feedback that responses to Form 13 is all over the place, that it may not really tell us how real the family engagement, family participation, family leadership in the state really is. So if it's not that, how else do we make sure that families front and center in everything that we do in maternal and child health? Again, this is where I need to hear from you. Your intellectual leadership, your guidance is going to be really important on this. And then just want to make sure that although these outcomes, some of them speak to preconception care, seem to be in the clinical realm, it does take a robust public health system to make all of these things happen, ranging from preconception care to maternal morbidity to stage fleet to school readiness to medical home to immunization, which is tied to our legislation. And so I don't want you all to think that these are primarily clinical performance measures. They really speak to the need for a robust public health system that are carrying out the public health functions of assessment, assurance, and policy development for the MCH population.
Thank you. I think that's the tone of the dialogue we're looking for, and to Wisconsin, another point of personal privilege as a Wisconsin native. I join you in mourning the end of the Packers season and wish you warm thoughts, as we know you're in zero temperatures, as is most of the country. So I share that warm thoughts wish with many of you. Let's keep going, operator. If we have other folks in the queue.
There are no further comments at this time. However, ladies and gentlemen, as a reminder, to register for a comment or a question, please press the 1 followed by the 4 on your telephone keypad.
So as people do queue up, and operator, just jump in as folks are on, there was that specific question that you just clarified on the 30-30-10 being a statutory piece. That doesn't add up to 100, does it? 30-30 requirement being in the statute. So thank you for doing that. We had an additional question on school readiness that I think you've addressed. Let's see, and we've had, and we realize this, the issue of just having the straw person measures in paper in front of you. And actually, I did include that as one of the attachments with one of the reminders, but as you know, you got a lot of emails, so it's back in there as a 2-pager. And I don't know if we can make the slides available to folks because I know there's more detail in there, but we will look to that. And let's see, what else do we have in the chat box. This gets to some of the theme that was just echoed there, that issue of are these medical care measures, are they public health measures? And I think the Institute of Medicine encapsulated this challenge pretty concisely when they said that the challenge for us in public health now in this environment is to both integrate with medicine and to differentiate at the same time. And so that is kind of a tension, I think, that we're acknowledging, that integration and differentiation at the same time. So one of the questions was along the lines of the components of the Well Women visit and what would be the reference that defines those components over time. I don't know, Dr. Liu, if you could address that with the background on the components for the Well Women visit. I think it's related to preconception. It must be in relation to the preconception care measure. Is that the one that gets to Well Women? And the question was to clarify what the definitions. Is it the U.S. Preventive Force Task Force components or those promoted by ACOG? Which guidance would we be following? And if that's not clear enough, if the person that asked the question wouldn't mind jumping in the queue, I think it's easier if we just have them directly. And another comment along those lines, that the preconception health is broader than preconception care, so just that sensitivity to the phrasing. Let's see. There's a number of questions here. We're getting to the issue of measuring around depression, maternal depression, youth depression, suicide, and the broader issue of social, emotional, mental health. And if you could provide some thoughts on that piece.
Yeah, let me just comment as a group. I think these are just tremendous questions, and they're exactly the kind of dialogue that I'd like to have nationally. We I know that our measurement work group did a lot of discussion about the need to have some measure around mental and behavioral health, and we went back and forth. We talked about using treatment for depression as a possible measure that somehow didn't work out. But love to hear from you in terms of what you think of some viable measures might be. Again, needs to be national in scope, state representatives have annual updates at our strategic for Title V, that this is something that Title V can actually do something about, that Title V can move the needle on. And that speaks to some of these other comments around measurement as well. And again, would really love for y'all to provide input on what are the right measures. And so when you send your comment to me, tell me what would be important for Title V to work in, but also just how we go about measuring it. That's the kind of comment, that's the kind of intellectual leadership I'm looking from y'all. And again, I see there's a number of comments around the whole public health functions. And again, okay, when you think about public health, it is about thinking about having those programs, policies, systems in place. Some of them don't make easy performance measures, but they do make important structural and process measures. And that's why we really kind of need to think about what are some of those performance measures that can help us tell the story, a national story about the impact of Title V, and what are some of the structural and process measures that we want to make sure are in place so that we're assessing the robustness of our public health system for MCH population in the states. And the third component of that measurement are the population outcome measures. Some of these are legislatively required. A lot of our old performance measures, or indeed some of these population health measures, there's some movement away from these, really because, as you all know, there are too many factors that affect these population health measures. For example, I used the example of infant mortality in the video, and so it's hard to hold Title V entirely accountable for infant mortality, but there are probably things that that contribute to that infant mortality that make really good performance measures that we can demonstrate the value, the impact, the return on investment for Title V. And that's what the current thinking about in terms of this performance, in terms of the measurement framework, that will retain some population health measures that are legislatively required. We're focusing on performance measures that Title V can move the needle on and that are measurable. And then we're thinking in terms of structural and process measures to make sure that the program's policies, systems are in place to carry out the public health core functions of assessment, assurance, and policy development.
Great. Let me encourage again people to use the phone function. Operator, do we have somebody?
There are no phone comments at this time.
Good. So yeah, please do queue up. And can you just remind people real quick the best way to get in the queue?
Certainly. Ladies and gentlemen, you may press the 1 followed by the 4 on your telephone keypad.
Good. And while we're waiting, we've got about 10 more minutes, I think, for dialogue and then some wrap-up. There were a couple of checkbox questions, one on clarifying separation of federal funding accountability from state match accountability. Dr. Liu, if you could speak more to that, if you mean the match, let's see, it says, did you mean match or state funding related to our MCH work?
Yeah, it's really, I think that when we're talking about separating federal and state funding, we're really talking about accountability for how the federal dollars are spent. And for most of you, I don't think I need to explain the reason why we need to do that. So I think that's as far as the accountability goes. States should still have the flexibility to use your own state dollars to address your needs and your priorities, but we want to make sure that when federal dollars are spent, that there's good accountability for that, and whether that's spent on your state needs and priorities, whether that's spent in driving some of these national performance measures, that states should still have the flexibility to do.
Great. Got a comment regarding the reduction of data burden on each state. The national surveys are helpful for overall prevalence rates for broad topic areas and can allow for models looking at associations. However, there's limitations. People wanted to share, unable to conduct mediational analyses to look at controlled direct effects. Let's see. These are really hard to do by, like I said, I think it would be easier for folks that want to comment if you can get in the queue. We'll certainly have a chat log that we can share after, but I think if I could just stress that it's just easier to engage in dialogue if you can explain through the 1-4 to get in the queue. So folks that have extensive comments, if you could do that, or certainly we can follow up. And again, I know Dr. Liu had mentioned the email box that's been set up, and we'll share that again at the end. But for right now, I think for dialogue and listening, if I can encourage folks to jump into the phone queue is probably easiest. Having said that, we got a couple here that are shorter and easier. One is a question about injury, just making the point of it being a leading cause of death for both children and young adults, and some of the thinking behind whether that should be included as a measure or not. If you could address that, Dr. Liu.
Sure. I think certainly our internal work groups have also discussed injury and violence prevention. So I'll throw the question back out to you all, whether you think that should be a priority for the Title V block grant, a national priority for Title V block grant, and how do we go about measuring our success in injury and violence prevention. I see a similar question around nutrition and physical activities. And again, this is a strategic question because we know that some of the other agencies, some of the, for example, the preventive services block grant may be doing a lot of activities around that. So again, the question is, what's the unique contribution of Title V? And if we want to tell a compelling story about the impact of Title V, nutrition and physical activity is pretty broad. What's that space that we want to work in? What's the lane that we want to own? What's the needle that we want to move as a Title V program? So again, your input, your ideas become so important to us at this time, because recognizing that the real work of improving maternal and child health really happen on the ground at the state and at the local level. That's what I need to hear from you at this point.
Pardon for the interruption. We do have comments on the phone line at this time. Our next comment comes from the line of Bianca Pierce with the Louisiana Department of Health and Public Hospitals. Please proceed.
Hi, this is Nicole, the epidemiologist, for speaking on Bianca's line. And I had the question regarding the reduction of the data burden. I think it's a wonderful idea to have measures that are consistently evaluated using the same questions and same standards. It is a bit of a challenge with the national survey to look at occurrences that are rather rare. So, for example, if we wanted to look at genetic conditions using national survey data at our state, we have such a small sample size that the estimate's rather unreliable. And so I think if I were to make a suggestion about something that would be a tremendous asset to our programs, and I think it speaks particularly about what the fellow in Wisconsin was saying about other measures such as abuse, challenges that happen during childhood. things that would probably be also captured in other agencies. So, for example, Department of Education, Department of Social Services, military, through the Veterans Affairs. We have a tremendous number of young families who are now associated with the VA. So something that would perhaps link the National Center for Health Statistics, the DHHS data, with other national agencies. I think that would be very helpful. So that's just my suggestion.
Great. Thank you for that suggestion. I know we only have a few moments left, so let me again invite some comments and some dialogue, if not now, then through our email Dropbox. I'd like to hear from you about the 8 out of 15. Maybe it should be 5 out of 15. Maybe it should be 10 out of 15. Maybe it should be 5 for small states and 10 for large states. I want to get a sense of how you're all feeling about that, because we got to get that right, and so your input on that would be really helpful. Haven't heard that much comment about the pyramid, and I want to get some sense from you all whether you still find the MCH pyramid useful, and or whether you feel that that's really not serving you well in your state.
We do have another comment on the phone line. Our next comment comes from the line of Mary Reed with the Texas Department of State's Health Services. Please go ahead.
Yes. I addressed the topic of injury prevention as being a high priority for Title V. CDC lists injuries as the #1 mortality morbidity cause for people age 1 to age 44, and I think that gets our target population right there. So I'm curious as to the thoughts of making that a higher priority than it is. I think we can move the needle in motor vehicle crash related deaths. We can move the needle in drowning prevention, ATV injuries, those sorts of things. So at least here in this state, we see quite a bit of unintentional injuries, and then also in the area of intentional injuries, we're looking at suicide prevention as one of our high priorities.
And this is Brent from AMCHP.
Go ahead, Brent.
I was just going to share that this came up, and injury is a good example, and just illustrating what you all see is the challenge we're facing in getting the right set of performance measures. Injury is a great example where there is an entire center at CDC that is called the Injury Center, and when you look at this list here, you see that some of this is part of other agencies, and so in advocating for the block grant, that's been our challenge, is saying that this is something states are focused on and addressing that issue of if they're getting injury grants from CDCs, then what is the unique role of Title V? And there's a good example where CDC is only funding about half the states. So we know, that in a lot of states that don't have any CDC-funded injury infrastructure, Title V and maybe your Prevent Block grant provides the only infrastructure to address that. And in other states where you have a grant, it is probably inadequate. And so we're always trying to think of how we frame our measures in relationship to the public health system and have that added challenge that on a lot of these there may be another lead organization, and so we need to think carefully how we package these and explain them in a way that talks about how they're supporting the overall public health system. So just kind of to a lot of you, that's the obvious challenge, but adding that. And again, we're running low on time, but Dr. Liu did mention some specifics where it'd be helpful. So let me just check if people want to weigh in on that as we're moving towards closing comments.
Ladies and gentlemen, as a reminder, to register for a comment, please press the 1 followed by the 4 on your telephone keypad. And there are no comments on the phone line at this time.
Let me just, Jim, and Karen, my colleague Karen, if I could ask you, I know we had seen a couple come in on medical home, and if you wanted to jump in on part of the thinking around there and just a minute or two of dialogue. The issue we've been talking about is whether it's easier to measure that in components or as an overall. Do you want to comment on that at all?
Sure, and Dr. Liu, I was just going to point out, this is Karen Van Landa, I just wanted to point out a question that's come up, and I know it came up yesterday on the listening session and was also discussed at the work group level that maybe you want to comment on, is just this notion of medical home and how I think we've heard from states that it's a really important priority. States like it on there, but that there may be an opportunity to break it down a little bit and be more specific in terms of the actual aspects of medical home. And so we had a specific question to that on the chat function. So I wondered if you could talk a little bit more about the thinking around the medical home and some of the recommendations about breaking it out. So for instance, this particular person suggested receipt of care coordination and transition services as 2 ways to break that down more specifically.
Right, and certainly I think, again, I want to invite you all to continue to send your ideas and send your input about that. Right now we're seeing the medical home as a composite measure of 5 different components. I don't have it off the top of my head, but I know family engagement is one of them. I know regular sources of care, the ease of coordination. I believe transition might be a component of it, but so we're using it as a composite measure, but certainly entertaining any suggestions that folks may have in terms of maybe breaking down to different components with a special call out for example, for family engagement, or a special call out for transition services. So again, this is the more I hear from you, the better sense I get in terms of how you want to move forward with these performance measures.
So I think we want to move towards closing comments and just a little bit about moving forward. And I'd just say for this is Brent from AMCHP. On our behalf, it's been a pleasure to host this dialogue, and I think really enlightening and exciting about thinking boldly about the transformation and the future directions. I think we're going to hear again from the AMCHP leadership, but Dr. Liu, I'd invite you if you have some closing thoughts as we look to wrap this up to offer those now.
Let me just take a moment to thank all of you for joining on this listening session today. I'm sorry, I always wanted to do more listening and less talking, and I still end up talking way too much. And hopefully this is stimulating your thinking and that national dialogue and discussion and deliberation. As you get new ideas, new suggestions, please keep the ideas coming to our box, MCH transformation at HRSA.gov. We've probably by now received hundreds of these emails. And believe me, I do read each and every single one of them. And as I said in the video, there's no way I can make everyone happy, but I am looking for those common themes, those big ideas. And so if I hear from a lot of people that this is important, I'm going to know that this is important. So please speak up, because that's the only way that we can get this done. That's the only way we'll get to a common vision. This is what change looks like. This is what leadership is all about. I'm looking to you for that leadership to help us move the field, to help us improve, innovate, and transform the block grant. So I want to thank you for calling in today, and I do want to again take a moment to thank Brent and Karen and the staff at AMCHP, as well as Stephanie and Millie and the board of AMCHP for all their tremendous leadership and partnership. And with that, let me turn it back to either Millie or Stephanie.
Great. Thank you, Dr. Liu. This is Millie, and On behalf of AMCHP, I just want to thank you and your staff for the leadership that you've shown in transforming the Title V block grant. We value your partnership, and we look forward to continuing the work with you over the next several weeks and months as your vision for the MCH 3.0 is rolled out at the MCH annual meeting later this month, and then translated into changes to the block grant guidance in February and beyond. So I also want to just acknowledge a thank you to the states and those of you that participated in the call today, because without your participation, we wouldn't get the input, and this is exactly the dialogue. So again, thank you for being part of this national webinar.
I want to also, this is Stephanie Birch, and I want to echo Millie's thanks for the partnership with Maternal Child Health Bureau and for your active engagement and input from the states. I think we've had some outstanding dialogue today. Thanks for all of your questions as well. The AMCHP Future of Title V Work Group is going to continue to meet over the next coming weeks, and we'll be providing input to Dr. Liu on behalf of the AMCHP Board of Directors and states. If you have specific comments, please provide those directly to the MCHB through their webpage link that Dr. Liu mentioned. It's been created specifically for this purpose. You can also send any comments, or please copy, cross-copy Karen Van Landeham at AMCHP. Her email address is kvan@amchip.org, kvan@amchip.org. This concludes our listening session, and again, we have audio taped this session, and it will be available on the AMCHP website in the next week. Thank you so much for participating.